interestingly, the data from early studies on pseudoprogression have led us to treat often beyond progression with both immunotherapy and targeted therapy. So Reinhard, do you treat beyond progression even with targeted therapy? I mean, it's a different scenario.
Yes.
But
Yeah, it's a different scenario. So if I have a mild progression and a good control of major metastatic sites, I often discuss these cases together with my radio-oncologists, because radio-oncologists nowadays can help us a lot. So if there are metastases, they can more or less irradiate everything, not restricted to the brain with stereotactic irradiations, but also lung, liver, lymph nodes. And I don't know whether this will translate in impact on overall survival, but it gives a lot of confidence if you see that a patient is doing fine and there is 1 or 2 lesions that are not behaving the right way that we want to have them. And then you can just wipe them out by stereotactic irradiation and keep the patient with this in a close to complete remission. Therefore, I do this. I do this with both. I do
okay,
this with
but
immunotherapy
again,
and
this
targeted
is
therapy.
urban legend number 6, that you can have someone on targeted therapy, have progression in an isolated area, radiate it, and maintain disease control and not need to switch. I mean,
I agree.
Yeah.
I completely agree.
This is done in the routine, and all the clinical trials shows that 25% of the patients are treated beyond progression. This was a case with single-agent BRAF inhibitors when they were approved, but it's the same now with the BRAF plus MEK inhibition. And I think this makes perfectly sense. And don't forget, there's so many patients who have just a progression in the brain.
But there are,
So they're irradiated with stereotactic surgery typically. They have a nice response still in the extracranial organs. And so why should we stop the treatment? So we
but there's a
continue, but
contradiction here. We were just talking a little while ago about the fact that you should give a brief, not brief, but a burst of BRAF MEK, and then at the point when you think they're becoming resistant, switch to immunotherapy. Now you're saying when you think they're becoming resistant, you should radiate it and keep going. So I'm just confused which is the best path.
No.
But Jeff, resistance, and this is what we have learned, resistance is very heterogeneous from site to site. And we have this data now. If you can investigate the molecular mechanisms of resistance in one patient and investigate 5 metastases, the chances are very high that every metastasis has a different mechanism. So this means you have a subclonal development of the disease, and by just cutting just cutting one branch of the evolution tree of this tumor, you might do a good thing. We cannot prove it, but there is also a scientific rationale behind that.
Also, when you ask the question about treating beyond progression, BRAF, MEK, or immunotherapy, it's different. It's a different objective. When you have a patient who is obviously progressing under one or the other of this therapy, I think on one side, with targeted agent, when they are obviously progressing, sometimes you are afraid to stop if you don't have any other treatment that you can give, because you're afraid that if you stop, it's getting worse.
Yeah.
So you're afraid. With immunotherapy, you treat beyond progression very often because you hope that you will see a response coming. Sometimes
so that you're not confused with pseudoprogression, your original discussion,
Yeah.
because you're not, if the patient is doing well, if the ECOG is not changing, possibly even biomarkers like LDH is dropping, so all what you see and your radiologist tells you is possibly not true progression, and so you just keep on going, treating this patient.
in one side, you are afraid of worse, and in the other side, you hope for better.
Yeah.
Well, also, I guess we would agree there are differing mechanisms here. Some of the pseudoprogression may be just an inflammatory response around the tumor without actual progression, which is why the word pseudo is used. Sounds like with BRAF MEK, it really is progression, but I love the way that Reinhard put it. It's
Could be heterogeneous.
the tree got chopped down, but one new branch came, chop off that branch, the tree is still gone and you still have a remission. But again, doesn't isolated branching abnormalities prognosticate in the future for true resistance?
Dirk. Yeah, but I mean, several of these patients, which we have treated with targeted therapy beyond progression, had a very long benefit of the treatment. So, I mean, these are usually patients who are benefiting from this treatment 1 or 2 years before this limited progression appeared. So I think here it's clear that Reinhard's concept of chopping down one tree, one part of the tree is possibly a solution. Nevertheless, I think this was done in the clinical trials because we had no other option. And this was also done in the clinical practice because the options we had at that point were limited. I think now I completely agree. Could that be a perfect starting point, eliminating this limited progression and then switch to checkpoint blockade? Could that be the best decision point, controlling the disease otherwise? Again, as we have discussed previously, I think it would be important to test that in a clinical study.